Okay. Tonight's talk is on sports injuries of the ankle and the foot. We kind of cover Liz Franks in one of the other talks on midfoot injuries, and we also cover stress fractures in one of the other sessions. So this one's really going to concentrate on ankle injuries, specifically acute lateral ankle ligament injuries and syndesmotic injuries. And then we also cover osteochondral lesions in the talk on cartilage, which happens once in a 2-year cycle. So I'll start there. You guys see that all right, eh?
Can see it, yeah.
Okay, cool. Then. Okay, sports-related injuries. Just to catch your attention, what we're going to cover is just acute lateral ligament injuries to the ankle, and then syndesmotic injuries, and then we're going to discuss chronic lateral ankle instability. So this is a very common injury, and even if you're a generalist, you're going to see a lot of these. You're going to be referred them, and you're going to be treating friends, family with an ankle sprain. All of us have had one in our lives, mostly, whether we've been sober or not. So they're common, 25,000 a day in the US, and 302,000 in hitting A&Es in the UK, and up to 7 to 10% of all hospital A&E admissions are from acute ankle ligament injuries. And the list goes on. 30% of all soccer injuries are ankle ligament injuries. And the inversion supination mechanism is the most common mechanism, with twisting or rolling of the ankle. Up to 24 out of 70 sports analyzed by Fong showed that ankle ligaments were the most commonly injured, or the ankle was the most commonly injured joint out of all the joints. And we know from Hurtel's long-term studies that around 30 to 40% of ankle sprains do persist with some residual symptoms, be it instability, chronic synovitis, other things like torn peroneals, synovitis, or osteochondral lesions. Most FA Cup playing days are missed from ankle injuries. This is a multi-billion-dollar industry. Joe De Beer, one of the famous shoulder surgeons, he almost became an ankle surgeon because he realized this value. But then he went to shoulders and became a poor man. So with these very common injuries, it's pretty careful. It's pretty important to assess these patients carefully. And it's always beneficial to perform a delayed assessment. There's no point in evaluating someone who has a very swollen ankle, looks like a balloon. You may need at that time to splint them, to mobilize them for a short period, and then re-examine them once the swelling is down, because you cannot feel what's tender and what's not when it's swollen like a balloon. Once the swelling's down, you can assess for associated injuries. We advocate a short period of immobilization, be it a brace or a back slab or even a boot, and then instigation of functional rehabilitation, early controlled return to weight bearing and activity. In the past, prolonged casting was advocated. This is not good practice. Leads to atrophy, significant deterioration in ankle function, poor collagen regeneration, and stiffness. And then it takes twice as long to regain your neuromuscular training and proprioception following an ankle sprain if there's prolonged immobilization. So we did a study some time ago with Stefan. We did a survey of how clinicians treat ankle sprains. These are all orthopedic surgeons, and there was a wide array of different treatment modalities, and 34% of orthopods are still using plaster of Paris for an acute ankle sprain. And we know from some of the more common meta-analyses and Cochrane database that that is not the best treatment. What are the outcomes of an ankle sprain? Well, about 20% will have some ongoing instability or ongoing symptoms. And a repeat injury is the greatest predictor of a repeat injury is a previous injury. So if you have the second or the third sprain, then certainly you've lost that proprioception, plus you have perhaps some micro instability, which then becomes macro instability and can lead on to other problems like osteochondral lesions, impingement, anterolateral impingement, peroneal tendon tears, avulsion fractures, lots of other things that can cause chronic pain. How I manage an acute ankle sprain, these are, as I said, such common injuries that you certainly very rarely advocate surgery for any of these injuries. The fact that 15 to 20% will land up with chronic lateral ankle instability makes one think that perhaps we should be treating some of them more aggressively, but still you may be treating 80% unnecessarily if you offer all of them surgery. So there's certainly no evidence to suggest that they should be fixed primarily or sutured. So I try and base my treatment on evidence, and there's in the Cochrane database, a meta-analysis by these guys, Kerkhoffs and co from Holland, where they looked at a lot of different treatment plans, and they found with their meta-analyses that the best way of getting a patient back to functional, their previous function before the sprain, was to wear a lace of ankle brace for about 4 weeks, wearing it all the time, 24/7, even in bed, because when you lie in bed, you lie in plantar flexion and equinus, and at that time, your ATFL, which is torn and potentially healing, then is healing in a very stretched position, and you have a predisposition to chronic lateral ankle instability. So it's best to try and have the ankle held at 90 degrees for the first at least 4 weeks. And then weight bearing is tolerated. Weight bearing is a good marker for me, because if a patient's battling to weight bear after 10, 14 days after an ankle sprain, then I'm quite wary about an associated injuries such as an osteochondral lesion, a severe bone bruise, perhaps an unstable syndesmosis. So early weight bearing is encouraged. And then early controlled range of motion. So that means avoiding deep plantar flexion, inversion. Think of where the ATFL attaches, as you can see on that anatomical picture there. It's almost like the ACL of the ankle. They're two little bands that are almost horizontal, and they stop the talus from drifting forward. The calcaneofibular ligament insertion into the fibula is pretty close by and crosses both of the joints. It's tighter in neutral position and less commonly a cause of chronic instability. It's mostly instability of the ATFL that leads to the talus drifting forward and that anterior draw tester. And then physical therapy from about 2 weeks. And then the structure is to have a range of motion for 4 to 6 weeks, and then balance, proprioception, strengthening, etc. And then reevaluate. If there's a plateau in recovery, so they're not quite meeting the criteria for recovery, then one would re-examine them and look for instability, or or investigate with an MRI scan to look for intra-articular pathology. The professional athletes are a little bit different. They have pretty extreme functional demands and loads. Their return to sport is pretty critical, and you don't want to delay their return and lead to have a situation where they have instability if possible. And so I was involved in a little bit of research where during my fellowship we showed, based on a couple of meta-analyses and review articles, that you can get an athlete back to play a little sooner if you repair the ligament. So this is a small select group of patients that perhaps an acute repair or a repair of an acute on chronic type of injury. So if they've had a couple of sprains and then they have another one, you may then at that point repair this ligament primarily to prevent or reduce the chance of that 20% chance of recurrent instability. Look at this video. Some of these athletes, like this fast bowler here, are putting severe stress through their tibio-talar joint. You can imagine that ATFL is seriously tight and holding on to that talus and stopping it from drifting forward. So that elite group, perhaps they would, in some circumstances, benefit from acute repair. But ankle sprains can be associated and may lead to various other pathologies which need to be looked out for when assessing them. Osteochondral lesions, loose bodies, this thing called anterolateral impingement, which is analogous to the Bassett's lesion. It's a small avulsion of the distal inferior AITFL, which sometimes folds into the joint, causes an impingement. Some patients develop chronic synovitis, and I think this a lot of the time this is secondary to a micro instability. The peroneal tendon tear is pretty common, particularly in chronic situations, and other things like anterior process fractures of the calcaneus, which with a supination injury, an avulsion from the bifurcate ligament of the calcaneocuboid joint causes a little fracture there. It's quite common to have persistent pain. And some of these supination inversion injuries do destabilize the syndesmosis. It's quite an uncommon mechanism, but this is something to be looked for with syndesmotic instability testing and other fractures that may be missed. These are just some common pathologies. An osteochondral lesion. This is the Bassett's lesion, as you can see with the fold of tissue going into the joint. There's a scope shaver saving it off, peroneal tendon tears, and sometimes they twist enough to cause a midfoot injury. So, and the problem with chronic lateral ankle instability is it starts off pretty subtle, and patients are pretty asymptomatic between injuries, or can be. And then they have a couple of sprains in a year and a couple of sprains in a year. And during that time, there is change in the homeostasis of the joint, and the talus tends to drift forward on the tibia. And we know that cartilage doesn't like load under shear. And this is a common scenario where I am presented with a patient in their 50s with severe varus ankle arthritis, and on deeper questioning, very regularly, the history goes that they had a couple of sprains when they were at varsity or at school, and the ankle was pretty unstable through their 20s and 30s, but it wasn't so bad. And then in their 40s, they were too busy doing their orthopedic finals or whatever, running their business. They didn't think to get it sorted out, and then they come to see me in their 50s with terrible ankle arthritis. So there's ankle arthritis is not common. It's very unusual to have primary ankle arthritis. It's usually secondary to either an inflammatory cause, acute trauma like a fracture, or instability. Those are the main causes. So just showing you the anterior draw test. It's like, that's how I like to perform the investigation or the examination, with my thumb on the neck of the talus and my hands wrapped around the calcaneus. And in that way, I'm fixing the talus to the calcaneus, and I'm pulling both of them forward on the tibia. The problem with doing it, as explained in the textbooks, with cupping the calcaneus with your heel, is that you, in many instances, can be pulling the calcaneus underneath the talus, so you're not examining primarily the ankle joint. So we're going to move on now to, are there any questions about how to treat an acute ankle sprain? Basically, very rarely require surgery, short period of immobilization, then re-examine when the swelling's down. An ankle brace is better than a boot, and casting and functional rehabilitation with physical therapy are the mainstays of treatment. Look for associated injuries. Okay, we're moving on to chronic lateral ankle instability. So it's important to understand the definition. So mechanical instability is something that the examiner identifies, so it's objective. it's like that anterior jaw test. I can feel that there's a difference between that anterior jaw test and the other side. So it's not latent, or it's not function. It's abnormal, put it that way. So it's clearly unstable. Functional instability is subjective, so the patient may explain that their ankle gives way, that they have frequent sprains that are symptomatic. They may even describe chronic anterolateral ankle pain and some local pain, local swelling with an effusion. Can be a bit variable. So it's and yeah, that's pretty much what I mean. And when a patient has a combination of the two, so mechanically you can feel as the examiner that this ankle feels very loose, and based on the history, the ankle says these things, then after a period of I'll just go back to conservative therapy, which is bracing. So I think an ankle brace is and has been shown to reduce repeat injuries. It's extremely good as a proprioceptive device in that it gets the peroneals firing. There's some tactile response to the bracing, and is a good preventer of recurrent injuries. And then obviously activity modification. If someone's trail running and it's not that important to them, perhaps you say, maybe run on the road. Anti-inflammatories. Orthotics can play a big role, particularly in people with a high arched foot or varus hind foot. Wearing a lateral heel post, a well for the first metatarsal, and then peroneal strengthening, balance, etc. And then once they exhaust that, then we can look at more of the surgical options, which I'll go into. But like if anything, you want to take a detailed history. You want to find out exactly how the instability started, what the first sprain was like, or the second sprain, what makes them give way, do they have any tightness, and then systemically ask about other joints, because a number of times I'll get a patient who's got a terribly unstable ankle and they've dislocated the shoulder a couple of times, or they've had 2 ACL reconstructions. So then they've got a bit of a collagen defect, deficit, and it might mean that when you come to your surgical strategy, you may then perform more of a reconstruction as opposed to a repair. Look for these intrinsic factors, which may be to deal with their collagen or their biomechanics with the severe hind foot varus, as you can see below. So just on inspection, you can gain a lot of insight by just looking at the shape of the leg from the hip and knee and down to the foot and the ankle, looking at their lower limb alignment. And a lot of these patients will have quite a neutral heel and a high arched foot. Biomechanically, it tends to put a lot of stress on the lateral ligaments, and they have a predisposition to chronic lateral ankle instability and a cavus type shaped foot. And there are a lot of different sources of potential pain in the area, but just trying to highlight where you need to put your fingers. Obviously, just check the Achilles tendon. A number of times I've had a patient referred who had a sprain or described a sprain months before and actually present with a chronic Achilles tendon rupture. So always just check that. Palpate the peroneal tendons. Palpate the syndesmosis, the distal syndesmosis. An acute ankle sprain may be a bit tender in the syndesmosis, but usually not higher than 4 or 5 centimeters above the joint. Palpate along the calcaneofibular ligament, which can be also tender if there's a peroneal tendon tear and vice versa. Palpate the anterior process of the calcaneus, and then feel the midfoot, feel the base of the fifth metatarsal, and obviously feel for the medial side of the ankle with a deltoid ligament injury. And sometimes these grade 3 injuries can disrupt the deep deltoid as well. So when it comes to chronic lateral ankle instability, once the patient has exhausted conservative treatment and you are confident based on your examination and your investigations that they have instability. You might be looking at surgical management. Now, most of these patients, I prefer to get an MRI scan on prior to any surgical intervention, because observing the ATFL is not that relevant. If you MRI a lot of people with no ankle symptoms, you'll find that they have ATFL changes because of a previous sprain that's quite stable, but it doesn't look normal. But the value is in looking for associated injuries or associated pathology like torn peroneal tendons or osteochondral lesions or loose bodies. So I do advocate getting an MRI prior to surgery if you have the resources. And if you don't, then at least perform an ankle arthroscopy prior to the lateral ligament surgery. So the surgical management, basically there's two different surgical strategies. One is a ligament repair or tightening called the rostrum ligament repair, and the Gould modification, which is slightly different in that the inferior retinaculum is advanced onto the periosteum or the fibula, and that also helps stabilize the subtalar joint because the retinaculum it inserts into the lateral border of the calcaneus. So lateral ligament repair is the gold standard. It's been reproducible and has really good results based on some not such long-term studies, but it's reliable, it's quite low cost, and what you're really doing is creating slightly thickened scar tissue on the lateral side of the ankle. And then the next surgical strategy is a lateral ligament reconstruction. Lateral ligament reconstruction is replacing tissue, of course, and this is either anatomical or non-anatomical. Now, the anatomical reconstructions are, the modern way of reconstructing the ligaments, finding the footprints of both or sometimes just the ATFL on the neck of the talus and the fibula, and then the non-anatomical reconstructions, the Christmas Snook, Dilwyn Evans. These are quite historical and not really practiced much anymore, where one in the past would harvest the whole of peroneus brevis, root it through the fibula and the neck of the talus. But a lot of the time, this really made the subtalar joint very stiff, and I've had to do a number of subtalar fusions following one of these procedures done, 15 years prior or 10 years prior. So they're really not practiced much anymore. So it's more an anatomical reconstruction like you would with an ACL, PCL. And then whether you use an allograft or autograft, and the autografts are variable. I mean, you can use hamstring, some of the extensor tendons that are sacrificable, plantars, a little section of peroneus longus. I use usually a third of peroneus longus as a nice little free grafter. And then you can find the footprints, and pretty much it's just an illustration of how you can reconstruct the calcaneofibular ligament and the anterior talofibular ligament using interference screws and get a really nice reconstruction, and then perform a rostrum on top of that. What's become quite topical now is internal bracing. I know it's certainly also in the knees, where one would perform a rostrum ligament repair and then put an internal brace fiber tape over the rostrum, as in this illustration here. And that is the goal would be to make it immediately stable, to increase to decrease the time to return to play or recovery, and then protect your repair while it's healing. The naysayers, like I am a little bit, say that this is a bit of a stress shielder, and eventually it'll break like anything non-biological, and then the native tissue will be a little shielded, and it's not. And if you can make some mistakes doing this, make it too tight, you can put it in the wrong place. I've had to take one or two out that have been put in the subtalar joint. So it needs to be used well and with caution. And it's really just helping your repair. The most important thing is getting a good rostrum so that you have good biology, so that and this internal brace just acts as a check rein to stop the sutures from the rostrum pulling out. This is just an example of a patient who had an internal brace, nice smallish incision, very loose pre-op, and then nice and stable anterior draw. Promise you, I was pulling quite hard. The outcomes of lateral ligament reconstruction and repair, well, generally it's a pretty good operation, particularly the rostrum. We know now from some longer term studies, 5 to 10 year studies, that the rostrum repair, particularly in someone with either inherent lateral ligament instability, in generalized ligament laxity, and people who have biomechanical problems, like with a high arched foot or varus, that the rostrum tends to stretch out, and a higher percentage of people, if you follow them up for a long time, land up with a revision procedure. Obviously, if there's chondral damage and pre-existing cartilage problems, they do worse on scoring. This is sometimes you get pretty severe cases where there's severe chronic lateral ligament instability, peroneal tendon tears and dysfunction, and bad bony anatomy like this chap. And no matter what ligament reconstruction you do in this guy, it's never going to be enough to stabilize the ankle joint. You're going to have to do some bony work, and that can be quite variable, like a calcaneal osteotomy and a supramalleolar osteotomy, and occasionally first metatarsal dorsiflexion osteotomy to correct the first ray. You can see this is this chap's correction after 3 or 4 months. So yeah, in summary, for chronic lateral ankle instability, if you were to just make it very basic and summarize it into a short sentence, differentiate mechanical from functional instability. When a patient has a combination of the two and they've exhausted conservative treatment, then there may be a surgical candidate. An MRI scan is pretty important, I think, in my hands, because it rules out other associated injuries that you can't see on ultrasound or X-ray. Then it's worth a trial of functional rehabilitation with physical therapy and orthotic, perhaps. But if that fails, then surgery is required or an option. And then sometimes I actually, when the patient has severe instability with an effusion, I actually say, look, you really should have your ankle ligament stabilized, because there's a good chance of this landing up with severe ankle arthritis in 10, 15, 20 years, a bit like a very unstable ACL and the knee. And then you need to try and assess the patient's inherent hyperlaxity. If they're very hyperlax, you may then consider an anatomical reconstruction. And sometimes at the time of the surgery, when you perform your incision and you have a look at the tissue and it's very poor, then you will then perhaps go straight to an anatomical reconstruction using allograft or autografts. You need to have those things prepared. Any questions regarding chronic lateral ankle instability? I think if you kept it basic like that, where a rostrum is your gold standard, and a reconstruction for either revision cases, hyperlax cases, those with very poor tissue or severe instability. What's quite topical now is the arthroscopic rostrum, where anchors are put in arthroscopically, and the retinaculum and the surrounding soft tissue and scar tissue is plicated or pulled down onto the lateral fibula. Some of the studies and comparison studies have shown pretty good results. I have tried 1 or 2, but the superficial peroneal nerve and the sural nerve are right there, and you're pretty much blindly just pulling on scar tissue. You never get that nice fuzzy, warm, fuzzy feeling that you get when you've performed a open graft repair. So that's what I kind of stick to. Okay, so no questions. I'm going to move on to the high ankle sprain. So this is much less common. The syndesmotic injury is a different mechanism. Like this guy here, watch him being tackled from behind. And there's an external rotation motion or vector to the ankle. And the sequence goes that the anterior superficial deltoid ruptures or is injured or torn, and then the AITFL, interosseous ligament, and the PITFL, and can lead to varying degrees of injuries. This pretty beefy blue ball was tackled about 8 weeks ago by this chap, Peter Steff, and had a severe syndesmotic injury. That's the talus here. That's the fibula moving just with doing what's called the fibula translation test. You can put a shaver between the tibia and the fibula. You really shouldn't be able to get anything between it. It's a very tight joint. And landed up with a reconstruction there. So this is a very common injury in contact sports, but as a percentage of ankle injuries, pretty uncommon in comparison. Only about 18% of all ankle sprains, but there's quite a variability in extent and severity. They have a high association with osteochondral lesions. About 40% have some sort of chondral damage, which may need treatment or not. And most significant ones, grade 2Bs, have a deltoid ligament injury. They're quite unpredictable. They're quite heterogeneous, and that's the sort of mechanism. It's quite common, very common in rugby. In the rugby season, I'll treat at least 10, 15 guys with bad injury. The problem with syndesmotic injuries is that they have quite an unpredictable return to play. There's a fairly high risk of latent instability, where they build up this significant syndesmosis in the anterolateral gutter, which can lead to persistent pain, swelling, anterolateral impingement. Obviously, with the AITFL being unstable, the fibula can move forward, and then they get also translation of the talus, chronic pain, heterotopic ossification of the interosseous ligament, and obviously, if it's very unstable, arthritis. If you look carefully at the anatomy, it's very closely related to the lateral ligament, the anterior talofibular ligament. So sometimes an injury of the ATFL will feel like a syndesmotic injury because it's very close by, and occasionally the very inferior part of the syndesmosis can be injured in acute supination injury. But generally with an external rotation injury, there's no damage or injury to the ATFL. With external rotation, the deltoid is torn and the interosseous ligament and AITFL is torn, and the ATFL usually remains intact. And most of these guys, when you perform an MRI scan, the ATFL is intact. Syndesmosis completely ruptured. There's fluid between the tibia and the fibula, and the superficial deltoid is torn. That's a severe injury. So when it comes to assessing these, it's very obvious that the syndesmosis is gone here as it is there with this mesonerve type fracture. But sometimes you get this picture where the patient has an absolutely normal looking x-ray, but every positive sign. And on clinical examination, the important salient findings are when performing the squeeze test. So squeeze test is squeezing the tibia and fibula around the midshaft, and that then causes plastic deformation of the fibula or bowing, and then that moves away from the tibia. That should cause pain distally at the syndesmosis. External rotation pain, so that's externally rotating and causing pain at the syndesmosis. But I find the most important finding is palpation of the syndesmosis up above 5 centimeters from the joint is generally pretty pathognomonic of a syndesmotic injury. And then the fibula translation tests and the cotton tests, which are really just grabbing the fibula and moving it in either the medial lateral plane or the sagittal plane, trying to get to feel. The problem is in some of these cases, as you could see from that previous video, these instabilities are quite small. The fibula is moving, 3 millimeters more than it should, and that can be difficult to differentiate clinically. And sometimes they have quite significant injuries despite that. So I was kind of involved in helping to establish a classification system for this, which is now being been picked up in consensus paper, but we don't really know what instability is. This is a case of a patient who came 4 months after an external rotation injury. You can clearly show the synovitis there. The fibula is moving way too much. We could get a shaver between and the hook between the tibia and the fibula. This patient was pretty uncomfortable. This is a patient who had no fracture, just an external rotation injury. So I was involved with this paper where we found that the summary was that if a patient had a deltoid ligament injury with pain about 5 centimeters above the ankle joint, if there was an external rotation mechanism, and if the ATFL on MRI was intact, that all kind of fitted together and suggested that the mechanism was suggestive of a syndesmotic injury, then at ankle arthroscopy, they were all found to be unstable with the ability to pass a shaver between the tibia and the fibula, and they were stabilized. And we don't really know what the best way of stabilizing these instabilities are. Screws or buttons, whatever, as long as you can make it stable. My decision making is based on some common sense and a little bit of biomechanical studies. When there's a major nerve type fracture or a fracture around the midshaft or higher, I think the tight ropes or suture buttons are not quite strong enough to control the length of the fibula. So then I think a screw is really good, and then maybe use a hybrid technique. We use a screw and a tight rope, and remove the screw after a couple of months. When there's no fracture, then and there's quite a large rugby player, I'll use or large patient, I'll use 2 tight ropes, slightly different angles to create control of the rotation. And then if there's a significant talus tilt following syndesmotic fixation, then one can infer that there's a significant deltoid ligament injury, and perhaps would fix the deltoid at the same time. And there's quite a lot more emphasis on the deltoid now, and I think this is certainly pretty topical. But we don't really have any algorithms to follow, bar performing a tilt test on the table, and if there's significant tilt more than 12 to 15 degrees of valgus tilt, then one should repair the deltoid and try and get it back onto the tibia. So yeah, basically 3 grades of syndesmotic injury without fracture. Grade 1, where there's no diastasis. Grade 2A, where there's no diastasis, but injury to the interosseous ligament and the AITFL, but no deltoid ligament injury. Grade 2B is deltoid, AITFL, and interosseous ligament, and a grade 3 would be all 3 ligaments and the deltoid. It's just a case showing a significant instability, and then following the single tightrope, she was actually a ballet dancer or something, very lax. Generally, I could get the scope in there, nice and stable afterwards. And this is just reiterating what the consensus statement was. Following that was pay careful attention to pain up the interosseous membrane, and then for pain over the deltoid. It's very similar to assessing stability of a fibular fracture. If there's no pain over the deltoid, the talus can't really go anywhere, and they're unlikely to have an unstable situation. So if you have an oblique, or if you have an unstable syndesmosis plus a deltoid ligament injury, there's rotational instability, and probably you need to address that. So yeah, in conclusion, ankle sprains are terribly common. I think a brief period of mobilization and then functional rehabilitation for supination inversion injuries, careful examination at a delayed setting when the swelling's down. Surgery only for very severe gross injuries, perhaps professional sports people, patients who have an acute on chronic injury. Sometimes they do well with surgery where they've had a couple of sprains and now they just want to get it fixed for the last time. Just remember, syndesmotic injuries, the mechanism is different in most cases, can lead to chronic problems and often missed. In more subtle chronic micro instability, I find ankle arthroscopy pretty useful to pick up synovitis, and then you can assess arthroscopically the anterior draw test. Also look for the syndesmosis. Got a low threshold to perform an ankle arthroscopy following an MRI in someone who has an ankle examination. It's quite difficult to interpret. And then the external rotation mechanism for the syndesmotic injury.